In this episode of Tuning Healthcare, I'm joined by Dr. David Zaas, the new Chief Executive Officer of Medical University of South Carolina's Health Charleston Division and the Chief Clinical Officer of MUSC Health. David and I discuss the role of leadership and how it now more than ever, it is critical for healthcare leaders to step up. We also talk about the role of the academic medical center and how it needs to evolve to meet the new challenges. And perhaps most importantly, David gives us a blueprint for what is necessary for a health system to do to be successful in the post-COVID world. Join David and I as we tune healthcare. David, thank you so much for joining me today. Delighted that we've got this opportunity to discuss healthcare. It's obviously such an important topic for the country. But before we jump into COVID and the future of healthcare, I'd love to start by understanding, how did you get into healthcare? I read recently that you were the first in your family to leave Ohio, and now you've moved. You keep moving south, and who knows where's next after this. But love to learn a little bit about your story.
No, thank you, Nigel, and for the opportunity to get to share a little bit of the story and talk about some of the amazing work that our teams are doing. Talking about myself, you're right. I grew up in Cleveland, Ohio, and the family is still there. And I left at 18 and have had an amazing journey. And I think, right, especially now in the world, right, we get to appreciate how thankful we are for all the opportunities that we have, not only our health, but for the chances to lead great organizations. So short version of a long career is I'm a physician scientist at heart and absolutely passionate about academic medicine and the ability of academic health systems to really transform healthcare. And I started my career as a physician scientist, trying to understand the pathophysiology and basic science of organ rejection and lung transplant, and really have had the fortune of having amazing mentors throughout my career and journey from a physician scientist to leading a world-class lung transplant program at Duke to leadership roles in the School of Medicine, faculty practice, and then for the last 6 years as the CEO of our hospital in Raleigh, North Carolina, and leading Duke Health System's strategy in one of the most competitive and rapidly growing markets in the country. And I'm now 5 weeks into my next adventure as the CEO for the Medical University of South Carolina in our Charleston division, and a chief clinical officer for MUSC Health, which is a dynamic and rapidly growing academic health system serving the entire state of South Carolina. So I could not be more excited about the next challenge.
That's great. And the wealth of experience that you bring is clearly formidable. So I'm really looking forward to this conversation. Tell me a little bit, how did you switch from the clinical side to the administrative side? And what was that like? And did you feel you had the skill sets as to do that? And what were some of the gaps and how did you fill them?
Yeah, I think when I reflect on my career, I think each of the different roles, while it may sound convoluted, right, gave me some real skills that enabled me to be successful in each of the subsequent roles. So I'll even start before I was even busier as a clinical leader. I was really trained as a physician scientist and writing grants and publications, but really learned some unbelievable skills around how you build teams, how you solve problems, how you make arguments, right, to successfully get funding, And maybe most importantly, right, how you tell stories to tie these different threads together. And I had some unbelievable research mentors at Duke, but my clinical passion was lung transplant, and was fortunate to lead one of the largest lung transplant programs in the country, to not only some of the largest volumes of 150 lung transplants a year, but outcomes and research productivity, and realized that my real passion is working with teams, leading people to solve problems, and really make that impact around the health of the communities. And while I loved my science, I was really passionate and excited about the opportunity to lead people and teams. I thought for a lot of my career that would be within transplant and more clinical specialties. But even in that sense, I realized I needed to get the skill sets. So I went back to Duke and got my MBA about 15 years ago, and realized that in order to lead programs and to lead people, I needed to really understand not just what I needed as a clinician and a scientist, but I really needed to understand the finance and business world that is healthcare. And the opportunity to solve problems in healthcare, working with other business school students that were outside of our industry, was absolutely fascinating. And I realized there was so much we could learn from other organizations. The series of changes after that were really not intentional. I loved each step along the way, but it was, if you're doing really well in a role, I was fortunate that, other mentors found me and said, we want you to stretch and to try something different. And then looking back on 20 years, in many ways, right, the skills of not only a scientist and a clinician, but also learning how to lead in the School of Medicine, in a faculty practice, as well as a hospital and health system, differentiated me and gave me a perspective to say academic health systems should be leading the transformation of healthcare in this country. We are really positioned to not only lead the research and innovation, but really lead the transformation of delivery, of our reimbursement models. And so it was really a journey along the way that was not intentional. But it was really, again, I couldn't have charted a more perfect course from at least my perspective of enjoying every step along the way.
Right. That's great. I'm sure many people have said it, but I think it was Emerson who first said, right, it's the journey, not the destination, right, that really matters. And I can tell you that I try and deliver that message so regularly to my teenage kids that enjoy the journey, enjoy each step, right? Don't be so focused on the destination. And if you do the right things, work hard and enjoy the journey, take the most and give the most in every opportunity, the destination will more often than not be a good outcome. And you clearly embody that.
Yeah, I couldn't agree more. I think that's a critical component of being successful at each of those steps, is really trying to make that impact in each phase of that journey, as well as, for me, what really helped is the value of relationships and surrounding yourself with outstanding peers and mentors. And what excites me about coming to work every day for the last 20 years is the ability to work with, really passionate, talented people that have taught me so much in each of the different roles. And that's been the exciting opportunity about even stretching for new roles and new opportunities, has been the opportunity to work with other leaders that really inspire you for how they follow their values and how we really make an impact. And many things around the challenges we face in the world, right? Healthcare leaders are needed now, maybe more than ever.
Yeah, absolutely right. Before we leave Duke and your time at Duke, as you look back, what would be one thing that disappoints you the most? You wish you had achieved X, and for whatever reason, you didn't get it done, or the market wasn't right to achieve it, or some healthcare partner. We know healthcare systems are so reliant on a whole host of different partnerships and collaborations to be successful, wouldn't play ball. Is there something you look back on and say, I wish we would have done that but I didn't quite get that done?
So I'll pick one personally and professionally, and I'll go on to opposite ends of the spectrum. So personally, as I said, my passion has always been a physician scientist, and I never wrote my R01 grant or never submitted it. And I still to this day wish that personally as part of my journey that I probably would have continued the research journey a little bit longer and submitted and got funded with the R01 grant. And I had some amazing colleagues and mentors that I worked with that I really could have. But like many of us, we were juggling lots of things at the time when I made the transition. When I look at what we accomplished at Duke, I mean, so many things I'm so proud of. But to your question of what we didn't, I wish we would have even developed more partnerships. I think that there's a culture in academic medicine to think, we can build and we can do everything. And a lot of that we do exceptionally well due to the wealth of talent. But in the world that's changing so quickly, I think academic health systems need to really understand how to be good partners and how to create relevance through different types of relationships, different types of partnerships, not just for horizontal integration and growth, but vertical integration to really transform care delivery. So the one thing, Nigel, that I think and I would say most AMCs could do better is be more willing to take risk and enter into those partnerships to really bring value to other partners as well as the communities we serve.
So I'd love to explore the role of AMCs with you, because you obviously have as much experience perhaps as anybody in the country inside AMCs, the role of AMCs as we think about healthcare. And I'm sure those listening would love to hear your perspective. So use the term there, you wished AMCs would take more risk. And are you using that in terms of a business term, as like just take a chance here. Let's see if this works out, right? We don't live in the world of perfect, to sort of use a Silicon Valley-ism, right? Make it, just good enough and then, put it out there and then figure how you evolve and improve it. Or were you using it in sort of the take more financial risk? How were you thinking about the term you wish AMCs would take more risk?
I compare to my friends that are in different industries where we know the ability to experiment and fail fast and to really focus not on preserving the existing business model, but to try to be developing and shaping the future business model, right? Tech companies and others, I think, have over the last 2 decades really led in that ability and moving from different businesses to achieve what is their value proposition. And I think healthcare in general has tried for a long time to preserve a business model that has helped sustain so much of what we do. But I think AMCs have the opportunity to have unique partners, not just with other hospitals and providers, whether it's technology companies and payers, and to go back to the foundation of our mission, right? We should be the most mission-driven organizations of any industry in the country around improving the health of the communities we serve, educating all of our future leaders, driving the innovation and research to change what we do. For us to really achieve that at a greater scale and to accomplish things more quickly, we're going to need to understand different partnerships. So when I refer to risk, it really is saying, right, there is others out there that have core competencies that would really be synergistic. And how do we become nimble to identify those partners to figure out how we work together, to be willing to leverage our talent and brand to drive not just revenue and not just the existing business models, but to drive true transformation. Let's improve the health of the communities that we're serving. And to do that, it's going to be getting into things outside of what we do within the hospital. But that has to be our core value proposition that I think we're inherently within healthcare still we're preserving what we know and what we do really, really well. We do great sick care, best sick care in the world. But we aren't very good yet at realizing that to truly transform health, it's going to be through partnerships and new relationships in a very different way.
David, in the post-COVID world, does the pandemic force the academic medical system to speed up the move away from fee-for-service and say, I don't want to be in a situation where I have such little control over my revenue, and I'm gonna speed up that transition to take more risk and take more value-based care arrangements in order to have greater control over my revenue? Or does the AMC say, you know what, for the next year, 18 months, 3 years, whatever it might be, we've lost some revenue and we really need to double down on what we know best, which is filling as many beds as we can for as many specialties as possible?
So I think AMCs need to use the lessons from COVID to really drive change. And I think there's 3 things that come to mind that I think are going to drive that change. Most importantly, I think, is the health disparities that we've seen as a result of COVID. So although we have the best sick care system in the world, the health disparities within our vulnerable populations, within our Hispanic and Black populations, due to the socioeconomic determinants of health, should be really disturbing, I would hope, to anyone who's a leader in healthcare, to realize that despite all of our attempts, that the health disparities have made our vulnerable populations bear a huge disproportionate impact in the setting of this crisis. So our delivery model needs to change. Just providing the best care in hospitals and in clinics, right, isn't good enough. The second driving force for change, I think, is going to be a wave of consolidation. Hospitals, independent physician practice groups, I suspect many will struggle to survive. And if they survive, are going to realize they are at risk going forward, are going to need to be part of larger organizations and systems and different models. So I suspect both horizontal and vertical integration, as we see a wave of consolidation starting later in the year or into 2021. The final piece is the reimbursement models, is the fee-for-service model really puts healthcare at risk in this time where we are dependent around so many of the procedural services that drive revenue and the episodic care that drives revenue. And I hope will drive AMCs to realize we need to understand, if we want to improve health, if we want to grow, we need to have a stable business model that involves more premium dollars feeding into the system and a more consistent revenue stream to enable that growth and enable us to focus on all of the things that will really impact the socioeconomic determinants of health. So I think those 3 together means that the successful AMC and the successful health systems will change markedly over the next few years in what they look like, in how they deliver care, and how they get paid.
we could probably spend 2 hours just on those three. That's a great blueprint. But let me touch on maybe each of them really briefly and ask you a couple of things just to maybe elaborate on each one. So the first one is incredibly disturbing. Actually, one of Lumeris's missions is to help our clients ensure that the great quality of healthcare that they deliver is delivered to every person, irrespective of their zip code. And as you know, I live in the Bronx, and the life expectancy of somebody in the Bronx is 5 years less than Manhattan, which is just a couple of miles away, and obviously a lot of other reasons for that, but it shouldn't be the case, right? And so you spoke about transforming the delivery model. So I'd love you to just give us a couple of thoughts on sort of the clinical side. How I'm a big believer, having spent the last decade plus studying this topic, that the financial model and the clinical model have to be tied together. When they're separated, you either could have great care at extremely high cost, or you could have poor care at low cost, and that's obviously not a great answer for sustainable healthcare system. And so I believe so we've spoken a little bit about the financial model. I'd love your perspective, obviously, as a clinician, as the chief clinical officer of MUSC. How do you see the clinical model? What are some of the few things that you think, if you were to advise a health system, they must be doing around the clinical side of care that might be different to what they've done historically to try and reduce these inequalities that we see?
So, Nigel, I think the first thing that we need to focus on is really designing the care delivery model around the patient. And we've talked about that probably for a decade, but I would argue that it's still based around the provider. We still use templates and appointments and create barriers to access that no other industry has, that creates challenges for customers to access their services. And a lot of organizations in response to COVID are focusing on the growth of telehealth. But in many ways, right, we've taken the broken model of our clinics and shifted it to telehealth, but we haven't fundamentally changed how we deliver the care. You still need to call and make an appointment. You still need to be scheduled at a time that's convenient for the providers. You still are driven to a physician instead of a lower cost provider that could potentially see you more quickly and better meet your needs. So I think we need to, again, go back to the idea that the patients are our customers. And for us to really improve their needs and all of their health outcomes, the barriers to access need to go away. How we deliver services to them, how we deliver services in real time when the customer wants them, how we diversify the portfolio of our care team providers, how we transform the role of physicians to lead teams and probably do less primary acquisition of data, how we transform our EHRs to better utilize technology and artificial intelligence to allow that data to be utilized. So I think some of the celebrations of telehealth that we've seen in relation to COVID, it's incremental progress. And what we need is an incremental progress. We really need transformational change. And I think that there's an opportunity to do that, especially if we can line up the reimbursement models, that this will actually be a lower cost way to deliver those services. So that's just one example of, I think, again, with the guiding principle of if our mission isn't to deliver the best sick care, our mission is to improve the health of our customers. And realizing to do that, we need to make many more changes, and we need to do experiments. We need to be able to define how we do it, and we need to be willing to to embrace it and take some of that risk. So that's where I think putting the patient as our customer, we would do it totally differently.
Even the words, right? I'm a big believer that words matter. And even as you refer to the patient as the customer, as opposed to the patient, is even that little change of terminology is critical to changing how people think about it. I would imagine if we surveyed, most of the people that walked into health systems, they would say they walk in with a very different attitude or feeling to when they walk into a hotel, right? When they walk into a hotel, I would imagine 100% of them say, I feel, maybe 99%, there's no such thing as 100%, right? Would probably say, I feel like I'm a customer and I act like a customer and I have an expectation like a customer and I'm treated like a customer, not always, but a lot of the time. But when they walk into a health system, even if they're coming in for, a physician visit that's going to be, they might be in and out in an hour. They more often than not, I would imagine, say they feel like a patient, not like a customer. And I think that's you're onto something here, which I'm exploring, a lot right now. Is there really actually a enormous value opportunity for the health system now that stands up and takes a leadership role in really becoming customer-centric, because there's an opportunity now, with the advent of telehealth, to perhaps market to a broader audience, right? And therefore, for the health system that truly takes on your advice here to become customer-centric, I think has an amazing opportunity, not just for the health system themselves, but for the customers that they end up serving.
I couldn't agree more. I think the health system that really embraces all of technology, but maybe more important than the technology, the mindset of willing to put the customer first, all of a sudden, right, geographic boundaries of your market are now totally changed. Partnership opportunities, right, are totally different when we look at the patient as a customer and leveraging the ability of technology. So when I think around telehealth, while we've made baby steps, the two opportunities for us, right, are really breaking down all of those barriers to access. The other one that we haven't talked about yet is really lowering the cost for some of our highest acuity patients, for the ones where we're really consuming significant healthcare resources. So it's not just shifting in-person clinic visits to virtual visits, right? That's baby steps and it's incremental progress. But the real transformative change would be breaking down the barriers to access and really lowering the cost of that complex high acuity care by moving it outside of the hospital, doing it closer to your support network, doing it in the environment of your own home or other environments. And I think those are the areas that a few health systems are really starting to push, but we need to move faster.
Yeah. And on your second point around consolidation, who do you see? What do you see happening? Obviously people fear for the rural hospital, but who do you see being the consolidators, and who do you see needing to put their hand up and say, I need help here?
So I think all of us are worried about the rural hospitals. We know the rural hospitals had significant challenges prior to what we've seen with COVID. I think even large, high-quality physician groups that have been fully dependent around fee-for-service models and revenue realize that, right, their portfolio is not diverse enough to be sustainable. And I think health systems have realized with the differential impact between insurers and providers that we need to vertically integrate in terms of how we sustain more predictable revenue streams as health systems. So in my mind, it's a cascade, Nigel. I guess it starts with the idea that we're going to have an obligation as groups need help within vulnerable communities, within practice groups, to coalesce and form larger organizations in terms of how we horizontally integrate and become larger. I think the need of health systems to really have partnerships with payers and understand how to take premium dollar is going to be a critical step and maybe an inflection point that will change our delivery model. So now as a health system, if I am receiving premium dollar, I have new incentives to really drive health of the community. And then hopefully health systems are more aggressive at working with those partners to address all those socioeconomic determinants of health, because now we have even a greater financial incentive to keep those patients healthy out of the hospital that has been so detrimental. So I think it's not a big bang. It's not going to happen all at once. And I think there's sort of the three cascading steps, if I had to have a crystal ball, which would say, right, we're going to step up and we're going to help those practices and hospitals that are in need in those communities. And we're going to consolidate larger. The successful systems are going to enter into partnerships with payers and realize they need to be able to take risk and need to take premium dollar in order to have the best outcomes and to sustain their expense base. And then that last phase, which I think is the most exciting because it has the opportunity to really drive health, which is right now the incentives are aligned to saying, let's tackle a lot of those problems that we've talked about that actually keep our communities healthier and keep people out of our hospitals.
Yeah. David, we could probably go on for hours talking about, what we need to do. And I'm sure you would continue to be quite eloquent and articulate as to how we could do it. We like to close with what we call the quick fire round. What's the best piece of advice you were ever given?
So I would say that the best piece of advice that I was ever given was to really understand the importance of relationships and partnership. And one of my early mentors in my career really talked about that importance of no matter which side of any dialogue to ensure that our primary goal is to strengthen relationships and build partnerships. And that has really taught me well, and even in settings of conflict, to realize we are all striving for the same goal, and to be the best partner in relationship is absolutely critical to our success.
What do you do to relax, have fun?
So I have an amazing wife and two teenage boys that love to travel, especially prior to COVID, as well as love to spend time together outdoors, sports, hiking, skiing, surfing, rafting. And I look forward to getting through the challenges of COVID and getting back to our travel agenda.
That's great. And then if you could change one thing about healthcare, what would it be?
I think a lot of us know where we need to be and are impatient to get there. So I would accelerate the reimbursement model changes that I think are critical to helping us really achieve our full potential. I think we have amazing talent and people in healthcare, and especially in our medical schools and universities, and allowing our reimbursement models to change, I think will just unleash all of that potential.
David, thank you so much for joining me today. We've learned so much, and I'm sure we could continue to learn so much just from not just from your clinical and leadership perspective from a healthcare system vantage point, but also what you shared with us around teams, leadership, leading people. It's so important. And one of the things you said to me before we started the podcast, it's time for health system leaders to step up. And clearly you're one of those. And we wish you every success in your new role. Stay safe, stay well, and I'm sure MUSC will benefit enormously from your wisdom. So thank you so much for joining us today.
No, thank you, Nigel, and I enjoyed the opportunity, and hopefully we get to do it again.
Thank you for joining us today. Please follow us on your favorite streamer, and don't forget to rate us, as it helps others find our podcast. As we look to evolve and lead coming out of the post-COVID-19 pandemic, I hope you and your family continue to stay healthy. Please join us next time as we tune healthcare. This is Nigel Orenstein in New York.